Thank you, Dr. Rishi. So, yeah, most of the times we treat dry eye with giving some lubrication, but sometimes we need to dig a little deeper. What is the cause for dry eye? Now, I go about doing like this. If you have a patient who's complaining of irritation, if I have to do one test, whether it's dry eye or allergy, I would like to do a BUT. Almost all forms of dry eye would have BUT deranged. Then the next question comes, is it aqueous deficiency dry eye or is it an evaporated dry eye? And there Schirmer's test tends to help. In evaporated dry eye, the Schirmer stress would be normal or a little exaggerated sometimes. In fact, strangely, the patients will say they are watering and the doctor is saying you're dry. So that's the irony. In aqueous deficiency dry eye, the Schirmer's test would be deranged. Now, coming to Schirmer's just for a second, it's a good test to give you a diagnosis of aqueous deficiency dry eye. However, don't swear by it for your management. It's not a reproducible test. It's good for making a diagnosis. Now, this slide you saw with Dr. Vanathy. When we say dry eye, you have the environmental causes. Very commonly today is your computer vision syndrome where the eyes become dry. And you have the aqueous deficiency and evaporated dry eye. Now within the aqueous deficiency dry eye, let's see this case. A 50-year-old lady comes with pain, redness, diminution of vision and watering. She gave a vague history of putting some kind of an Ayurvedic medicine, some balm in her eye by mistake and developed this ulcer. She was on, like what Dr. Muscati had just mentioned, on antifungals, antibiotics, and a lot of medicines. 1 month, and this is what she was like. What are we dealing with? You look at the fellow eye, and that's again very important. Look at the fellow eye, and you see this very dry-looking eye. You dig a little deeper, and you find that the patient suffers from rheumatoid arthritis. You get investigations of RA factor, ESR, and sometimes ACCP, and you get your outcome. In India, very often, rheumatoid arthritis gets picked up by ophthalmologists more than the physicians. This is another patient who underwent a cataract surgery elsewhere, and within a few weeks of that, developed an ulcer. Again, of course, the doctor gets alarmed and puts the patient on a lot of medication. But look, what's the fellow eye status? It's an empty socket. Now, if you dig a little deeper, the history goes like this. Had a cataract surgery 6 months before that, develops keratitis and undergoes evisceration, was again put on a lot of medication for that. On taking history, how can two eyes behave similarly? There must be something in the body. The patient had rheumatoid arthritis with dry mouth and deformed joints. So this is something that is often overlooked, and we need to look at the person as a whole. This is a 55-year-old lady who presents with this picture. There's a thinning in the periphery, scleritis associated with it. Fellow eye also shows dry eye. C anca is raised, and with that, with the history, upper respiratory tract infections, symptoms, she had Wegener's granulomatosis. They need systemic medication, immunosuppression, disease-modifying agents to control the condition. Just topical lubrication here would not help. We controlled the lady, and then we planned a cataract surgery for her from an opposite side. Although she was on medication, she developed a perforation over here. So these are, any kind of surgery exacerbates the problem. Serum antibodies are useful. Anti-nuclear antibodies, rheumatoid factor, and the Sjogren's SS. This is the dry eye profile if you're looking for a systemic cause for aqueous deficiency dry eye. Another condition, very common, which is often overlooked, in the non-Sjogren's group, if you have absent sensations on the cornea, that's considered the worst form of dry eye. There is the afferent limb of the tear reflex doesn't work if the cornea is anesthetized. So cornea neural plexus plays a very important role in maintaining the environment of the ocular surface. We know herpes is the commonest cause among the infections, but our surgical procedures like refractive surgery and also sometimes very extensive vitreoretinal surgery where they use a lot of cryo causes a lot of harm to the ocular surface. And that's another condition which needs to be looked into. Tarsography works very well here, and one must look at this condition. Are the sensations diminished? Rarely we also come across congenital absence of sensations. The other very important group, of course, we'll be discussing that, I think, the meibomian gland disease, the most underdiagnosed condition in ophthalmology. This 52-year-old gentleman underwent an intraocular surgery, very unhappy, red eye persisting, watering, irritation, and we keep looking at the cause. Is there inflammation inside the eye? But look at the lid margin. The meibomian glands are inflamed. There's spouting of the orifices, blood vessels, telangiectasias around it, this frothy tear meniscus. These are signs of meibomian eye disease. Now, if on our Indian skin, it's not very easy to discern rosacea, but it's not something which is just a Western disease. If you see meibomian gland disease in young people, think of rosacea. And if you look carefully, you'll find rosacea-like picture in a lot of patients that come to the clinic. Of course, it's much easier in this expatriate who was in the US embassy. He kept developing chalacea, and here it's much easier to discern rosacea. So it's a cutaneous vascular disorder, and these patients will complain as soon as they go in the sun or they have a hot beverage, their face gets flushed. You look at their facial profile and you'll get your diagnosis of rosacea. Now, sometimes is it the cause or the effect? You have a patient like this in the clinic, and you see a lot of SPKs on slit lamp. Unfortunately, nowadays, I think we've gone the other way around, that we no longer use a torch. We straight put the patient on the slit lamp. So you see this picture on the slit lamp and you put, obviously this is what is causing the photophobia and the discomfort, and that's why the spasm. But is it the cause or the effect? Essential blepharospasm by itself can also cause dry eye. You give Botox to this patient and the filaments go away and the surface becomes better. Essentially, when you're having spasm like that, the tear film is not resting on the surface and the eyes become dry. So it's sometimes difficult to tell what's causing it. Is it the effect or the cause? Let's go to this patient, 36-year-old male, presented with diminution of vision, photophobia of 3 months duration. The left eye also showed an adherent glaucoma, had a previous perforation. He had some vague history of getting hospitalized for difficulty in swallowing food and water a month before. Had been diagnosed to have some esophageal ulcers which were without a proper diagnosis. There was a history of drug abuse and alcoholism. VDRL was negative, ESR was raised, HIV was non-reactive. Investigating him further, and on HRCT and X-ray, he showed pleural effusion. He was put on ATT. In the meantime, he perforates. We do a therapeutic corneal transplant, and he has just no epithelium. It just refuses to heal. Do a tarsography with not healing. What are we dealing with? We go back, and if you see this dry surface, are you dealing with SJS, Steven-Johnson syndrome? Is it catricial pemphigoid? The age doesn't match for OCP. For SJS, there's no history of drug reaction, eruptive skin disorder. And we've further investigated, and essentially this is vitamin A deficiency from malabsorption. And the patient improves with giving him high doses of vitamin A. So with these, I thought I'll just show you this whole spectrum of cases which can be dry eye. It's a multifactorial disease, and not all cases will be treated just with the lubricant. You have to find the cause. You find the cause, and then you may be able to get some relief for the patient. Thank you.